am Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and educator in Unacademy. I have an undergraduate and postgraduate medical science, and I have done my MBS and MD from Rajiv Gandhi University of Health Science. So today we are going to have a discussion on splenomegaly. Okay, when do you say splenomegaly? What are the various causes? What are the various differentials causing splenomegaly? Okay, and conditions like hyposplenism, splenic trauma, splenectomy will be discussed today. Also, the various causes of lymphadenopathy and various symptoms which has lymphadenopathy will be discussed in today's class. Okay, so before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform. There are a lot of benefits you can avail from this platform. Firstly, the daily live classes. So there are regular classes happening here, and there are various educators teaching in this platform. You can attend your favorite educators class, engage in discussions, and ask your doubts, and all these doubts will be immediately answered in the live chat. Next, coming to the structured course. So whenever you're preparing for your entrance exam, you need to have a structured approach. You need to plan really well. So by the time you give your exams, you would have revised very well. So here in Unacademy, all our courses are structured in line with your exam syllabus, and this is going to be a huge boost for your preparation. Next, coming to the live tests and quizzes. So again, whenever you're preparing for your entrance exam, you need to evaluate yourself. You need to analyze your performance. You need to what are your strong areas, what are your weak areas. And that is only possible if you attend as many tests and quizzes as possible. So here in Unacademy, there are regular tests and quizzes happening, and this will help you to evaluate yourself. And once you attend these quizzes, you get a detailed analysis on your performance. Next, coming to the unlimited access. So once you subscribe to the subscription, you get unlimited access to all the classes. Okay, so especially to the classes which are exclusive to the subscription platform. So even if you have missed a live class, you can go back and watch the recorded classes again and again. All this in the comfort of your home, in the comfort of your own device. Okay, so I highly recommend this platform. Using this platform from the beginning part of your preparation will go a long way. Fine. These are the top educators in the platform, and they have regular classes. You can attend their classes as well. Coming to the courses offered. So all the 19 subjects required for your NEET PG preparation are taught in this platform. And if you go to the Unacademy app, you can see various courses like the foundation course, the batch course, the crash course. So these are all the compact classes of various subjects. So you can attend these classes once you subscribe to the subscription. Next, coming to the NEET PG subscription package. So as you can see, the NEET PG subscription package varies from 1 month to 2 years. I would highly suggest the 1 year or the 2 year subscription. Okay, and 6 month subscription would be good enough for the students who are going to give their NEET PG 2021. So NEET PG, the 6 month subscription will cost you 20,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 8. Okay, for the students who are in their third year, in their final year, or in their internship where they do not have that much time to attend these classes, for them the best thing is to go for the 1 year or the 2 year subscription. The prices are very reasonable and economical, and whenever you find the time, you can go to the classes. So the 1 year subscription costs you 25,000, and using my code Shilpa, then you get 10% discount and will come up to 20,500. While the 2 year subscription costs you 30,000, and my code Shilpa 10% discount and to 27,000. Yeah. Hi, good afternoon, Aparna. So now without any further delay, we'll start today's class. First, we'll discuss about splenomegaly. So in splenomegaly, so in newborns, in children, around 15% of the newborns, 15% of the neonates, and 10% of normal children, and around 5% of adolescents. Okay, for them, normally you will feel the normally you can feel the tip of the spleen. Okay, normally it is that there is no other cause, but you can feel the spleen. Okay, so to tell if the spleen is enlarged, the spleen should be, especially the spleen to be palpable, the spleen at least 2 to 3 times enlarged. To be palpable. Okay, to be palpable. And what is the best position? Standing on the right side of the patient, side of the child, and palpating the abdomen. Okay, that will help you to feel the spleen better. So when a spleen is 2 centimeters below the left costal margin, so it is 2 centimeters below the left costal margin, it is called, it is abnormal and it is called splenomegaly, or it is abnormal. So basically abnormal. So when you feel, okay, splenomegaly. Okay, and whenever you see a superficial abdominal venous distension, so if you see veins distended, and if there is splenomegaly, what do you suspect? One of the most common cause in pediatrics. What do you suspect? So you can see the distended veins, then you feel a spleen. What do you suspect? So in these patients, you suspect portal venous hypertension. Portal venous hypertension, right? Yeah. So these patients generally with splenomegaly will complain of the left uh, upper quadrant pain in the abdomen. Okay, they'll complain of pain, and the best way to confirm is by radiology. You either get an ultrasound, you get a CT, or you get a technetium scan. So these will help. So the technetium scan, along with telling if the spleen is enlarged or not, it will also tell about the function. Okay, function of the spleen. Okay, so basically radiology will tell you about the USG, CT, and technetium scan. So this technetium scan will also talk about the function of the spleen. Function of the, okay. Now, so various differential diagnosis. So now tell me where are the conditions where we can see splenomegaly. So there are various hematological disorders. So one is main is the hematological disorders. So in hematological disorders, you see hypersplenism, hypersplenism, or splenomegaly. So the very important is globinopathies like thalassemia, sickle cell anemia. Sickle cell anemia, initially there will be a splenomegaly congestive spleen, and eventually it might go for autosplenectomy. Okay, so hemoglobinopathy, hemoglobinopathy. Then what else? Erythrocyte membrane disorders like the hereditary spherocytosis, right? Erythrocyte membrane disorders. Enzyme deficiencies like the pyruvate kinase or the glucose 6 phosphate dehydrogenase deficiency, right? Pyruvate kinase deficiency, G6PD deficiency, paroxysmal nocturnal hemoglobinuria. So these are the various conditions where there is splenomegaly, right? Next, what about certain conditions where there is extramedullary hematopoiesis? So there is extramedullary. So I've told you when the bone marrow is not able to produce as much RBCs as possible, there will be extramedullary hematopoiesis. Okay, so conditions like myeloproliferative disease, like the CML, myelofibrosis, osteopetrosis, petrosis. So these are some of the conditions with extramedullary hematopoiesis causing splenomegaly. Next, the very important are the infections, right? So the very important are the infections. So what are the various infections? Infections. So tell me some of the bacterial infections. See, it is very rare, but in salmonella there can be. It's a rare chance of having, but yes, in one is salmonella can be. Okay, chronic infections like, for example, in infective endocarditis, you have splenomegaly, infective endocarditis. Next, if, for example, if there is a local infection like splenic abscess can be caused by Staph aureus. Yes, correct, Sumitra. Salmonella can cause, but it's not a very important feature. But salmonella can cause splenomegaly. Yes, very important. So these are the some various bacterial infections. Fine. Next, coming to the viral infections. So, what are the viral infections which can cause splenomegaly? What are the viral infections? Yes, Epstein-Barr virus, very good. CMV, then herpes simplex. Herpes simplex can cause, okay. Rubella can cause, HIV infections can cause. So these are certain viral infections which can cause splenomegaly. Next, spirochetal. Remember, leptospirosis. Leptospirosis. Okay, rickettsial infections can cause. So now tell me, what is the difference between rickettsia and bacteria? I always ask this question just so that you'll remember. What is the difference between rickettsia and bacteria? What is the difference between rickettsia and bacteria? Yeah, so basically what is rickettsia? Rickettsia is also a bacteria, but to transmit the infection of a rickettsial infection can be only transmitted by the help of a vector. So rickettsia is nothing but a bacteria, but to transmit a rickettsial infection you always need a vector. Okay, so that is the difference. Okay, so rickettsial infection like Rocky Mountain spotted disease, spotted disease, Q fever, okay, typhus. Next, parasitic. So as yes, very good Sumitra. Malaria, Kala Azar. Yes, next. Kala Azar. Toxoplasmosis. Next. Toxoplasmosis. Leishmaniasis or Kala Azar. Schistosomiasis. Schistosomiasis. So remember so much, too much to one. These are main things you remember. So infections, bacterial like infective enteritis, when there is a local infection like abscess, salmonella you should know. Okay, cat scratch disease. So remember one more, cat scratch disease, brucellosis. Okay, just write down here, brucellosis, cat scratch disease. Okay, another very important is the miliary tuberculosis. Miliary tuberculosis. So these are the various infections which can cause splenomegaly. So now we'll talk about various immunological or inflammatory diseases which can cause splenomegaly. Immunological or inflammatory conditions. What are they? Immunological or inflammatory conditions which can cause splenomegaly. So very important, SLE can cause SLE, rheumatoid arthritis, right? Rheumatoid arthritis can cause. Next, serum sickness can cause. Then Sjogren's syndrome, amyloidosis, sarcoidosis. Okay, mixed connective tissue disease. Okay, so these are the various conditions for immunological. So these are main things to remember. Don't go too much into the cytosis, okay, or hemophagocytic syndromes. Okay, so these can cause. Okay, SLE, rheumatoid arthritis, serum sickness, amyloidosis, sarcoidosis, mixed connective tissue disorder. So these are the various immunological and inflammatory disease. So malignancy, you know, most malignancies can cause, like primary malignancies like leukemia, lymphoma, Hodgkin's disease can cause, right? Malignancies. Next is malignancies. Then metastasis. The more other solid tumors eventually causes metastasis and there will be splenomegaly. Next, coming to storage disorders. So tell me, what are the various storage disorders that can cause splenomegaly? Storage disorders. Storage disorders. So these headings you should know. So one is hematological disorders, then there is extramedullary hematopoiesis, then there is infections, then there is malignancies, then there is immunological or inflammatory conditions. Now we are talking about storage disorders. Now tell me certain storage disorders which have which are have which affects lipid metabolisms. Yes, yes, mucopolysaccharidosis, lipid metabolisms like Gaucher disease, Niemann-Pick disease, right? Then mucopolysaccharidosis, then 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 carbohydrate metabolism, carbohydrate. So in lipidosis only Gaucher's, Niemann-Pick. So remember like that, Gaucher, Niemann-Pick. Okay, mucopolysaccharidosis is one. Next, then if there is defects in the carbohydrate metabolism, carbohydrate metabolism is what? There is galactosemia, fructose intolerance, glycogen storage disease, right? Galactosemia, fructose intolerance, glycogen storage disease. These you have to keep in mind. Okay, so we not go to some of the other conditions. You will only get confused. So these are the major, main important conditions you have to keep in mind. The storage disorders which present with splenomegaly. One get yeah, glycogen storage disease. Fine. Next. Yeah. So next is congestive causes. So what do you mean by congestive causes? Where there is increased blood supply. What are the congestive causes? Congestive causes. So congestive causes being heart failure. Okay, if there is if there is cirrhosis or fibrosis of the liver. So one is heart failure. Then this portal venous obstruction, that is portal hypertension also can cause. So these are the various causes which cause splenomegaly. So remember these this way. One is hematological. Main thing is hematological disorders. You will know. Next, you all know infections. Thirdly, you all will know malignancies. Next, come to storage diseases and congestive causes. Finally, you go about immunological or inflammatory conditions. So whenever you get a question, be calm and see all the conditions. Okay, so this is in basic this is a slide of all the important causes of splenomegaly. So this you have to know. Okay, so this is something you have to know. Now coming to hypersplenism. So what is hypersplenism? What is hypersplenism? So what happens is there is increased splenic function. So what is the function of the spleen? It breaks down the RBC. So there is increased splenic function. There is increased splenic function, and as a result there is cytopenias which you see in the peripheral blood. Cytopenia. Okay, and if because there is cytopenia, there is increased bone marrow activity, and eventually there is increased RBCs which are produced, are killed in the destroyed in the spleen and results in mechanism. Okay, so this is hypersplenism. So in hypersplenism, basically the problem is that increased splenic function. So increased splenic function will lead to a cytopenia in the peripheral blood. There will be increased bone marrow activity to splenomegaly. Okay, so this is generally this hypersplenism is generally secondary to a second underlying disorder. So if this underlying disorder is treated, then you can avoid hypersplenism. Okay, so if the underlying disorder or the underlying condition is treated, you can avoid hypersplenism. But in some cases where you cannot manage, it might go for splenectomy. Okay, so the management over here is treat the underlying condition. So in refractory cases, you can go for splenectomy. Okay, so this is about, yes, very good, Sumitra. So hypersplenism is uh, when there is increased splenic function which leads cytopenia, and eventually there is increased bone marrow activity and there is splenomegaly. Okay, so that is hypersplenism. Yes. Now tell me what is hypersplenism. So before that, tell me, have you heard about Banti syndrome? Banti syndrome. Have you heard about Banti syndrome? Banti syndrome. So what is Banti syndrome is something but congestive splenomegaly. So there is obstruction. There is some kind of an obstruction in the portal vein or the splenic vein or the hepatic vein. Okay, which will block the circulation in the spleen, and as a result there will be splenomegaly. So that is called congestive splenomegaly due to obstruction in either the hepatic or the portal or the splenic vein, which will obstruct the splenic circulation. Okay, so that is Banti syndrome. Banti syndrome. Iron related. It could be. So basically any condition which causes obstruction to this vessels. Okay. Basically forget about the what is the underlying condition. So what happens is there is congestive splenomegaly. There is congestive splenomegaly because of a secondary condition which is causing an obstruction to the these three vessels, and as a result the splenic circulation is obstructed and it leads to congestive splenomegaly. Okay. Okay, so remember Banti syndrome. Fine. So this term is there in Nelson. That is why I just wanted to put it over here. Hmm. Correct. Okay. Now coming to hyposplenism. So what is hyposplenism? So there is decreased activity of the spleen. Fine. So there is decreased activity of the spleen. So generally this congenital. So tell me certain conditions or there is complete absence of the spleen. So tell me certain conditions where there is congenital absence of associated conditions with the congenital absence of spleen. Congenital, if there is a congenital absence of spleen, what will be the other uh, associated conditions in the body? Like if there is a spleen is absent, okay, congenitally the spleen is absent, then what associated property, I mean features do you see? Should you suspect? So when there is congenital absence of spleen, you should see if this child has a complex cyanotic heart disease. Complex cyanotic heart disease. Heart disease. Okay. So if there is any dextrocardia, okay, or if there is any bilateral, the trilobed, yes, right, isomerization, very good. Trilobed lung, trilobed lung, bilaterally. Okay, then any ectopic organs, okay, in any ectopic organs. So these are the things you have to see. Okay, when there is a congenital absence of spleen, you have to suspect this child could have a cyanotic heart disease, complex cyanotic heart disease. There could be dextrocardia, there could be trilobed lung bilaterally, or there could be a ectopic organ. So this should keep in mind. Okay, so this is something you should know. Yeah. So another very important thing is in hypersplenism can happen in, yes, sickle cell anemia. Very good, sickle cell anemia. There is something called as functional hyposplenism that is seen in malaria as well. Okay, it is seen in malaria. Certain autoimmune disease like the celiac disease is also seen. So certain celiac disease also autoimmune disease. Like celiac disease is an autoimmune disease, right? So we just put the main headings. I don't want to write autoimmune diseases. Okay, so like the celiac disease, it is seen. Very good. What are the other autoimmune diseases where you can see Fanconi anemia, Pearson syndrome? You can see. Okay, so these are various conditions where you will see hyposplenism. Okay, so in hyposplenism, when you do a peripheral smear, what do you see? What bodies do I have told you already one condition. Wow, you see something when you do a peripheral smear, you see something. These are inclusions in the RBC. What do you see? It is a feature of following splenectomy or asplenia. You see that. So, what is the peripheral smear picture? What do you see? You see Howell Jolly bodies. So, remember this Howell Jolly bodies. Okay, Howell Jolly bodies are a feature of hyposplenism, so that you have to know. Okay, and also when there is hyposplenism, there is reduced immunoglobulin IgM memory cells. Right? So as a result, when there is hyposplenism, these patients can have severe sepsis. There is an increased risk of severe sepsis. So there is increased risk of severe sepsis, especially with the encapsulated organisms. Yes, very good, Sumitra and Aparna. It's well joined body. So increased risk of sepsis with encapsulated organisms. And therefore, antibiotic prophylaxis becomes very important in these. Okay, next coming to splenic trauma. So tell me, so generally when there is abdominal injury, there could be splenic injury as well. So abdominal trauma leads to splenic injury. So this again, there is based on the kind of injury, there could be a bleed or a minor pain in the shoulder. So if it is a mild, small splenic capsular tear, if it is a small capsular tear, if it is a small capsular tear, what can happen? This patient might have an abdominal pain or a referred left shoulder pain. Okay, that is because of the irritation to the diaphragm by the blood. That is why there is a left shoulder pain. So either there is an abdominal pain or there is a left shoulder pain. So this left shoulder pain is because of the irritation of the diaphragm by the blood. Okay, so this happens in such patients, don't do anything, just observe. So observe, check, have a regular monitoring of the hemoglobin, so that it suddenly doesn't drop, and you have to see that this patient requires surgery if he or she suddenly deteriorates. The small capsular tear. So next, if it is a larger tear, so what happens in larger tear? There will be more blood loss, severe blood loss. So larger tear, there will be severe blood loss, and this patient might present with hypovolemic shock. Okay, so in such conditions, this patient might undergo laparotomy. So here, okay, yes, very good, Aparna. Okay, so here these patients might require laparotomy and blood transfusion. But blood transfusion is not so much. Also, you shouldn't be you should limit it to 25 ml per kg. Okay, in 48 hours. So in generally in children we give up to 10 to 20 ml per kg per day. So over here you should limit up to 25 ml per kg per day for 48 hours. Okay, so this is it. This is the main thing you should know. So basically there are two types. If it is a small capsular tear, there will be abdominal pain or the left shoulder pain because of the irritation to the diaphragm by the blood. And in larger tear, there is severe blood loss, and these patients might present with hypovolemic shock, and they might need laparotomy or surgical intervention to be managed. And when there is severe blood loss, these patients will require blood transfusion as well. Next, coming to splenectomy. So in so many conditions, like in thalassemia or in sickle cell disease, there are so many immunodeficiency disorders like viscodilatory splenectomy might be needed. But in splenectomy is one thing which we wait for the child to attain at least 5 years of age. Okay, so since once splenectomy is done, there is a high risk of infection. So especially in children less than 5 years, there will be increased risk of sepsis. Risk of sepsis if splenectomy is done, and that itself can lead to mortality. Okay, so that is why splenectomy is weighted in children for above 5 years, at least with 5 years, and only then undergo splenectomy. So before undergoing splenectomy, child should receive vaccination. So what are the vaccinations he or she receive before splenectomy? What are the vaccinations? Yes, capsulated organisms. So tell me, what are the capsulated organisms? Main three organisms which can cause. What are the three organisms? Okay, so tell me the three organisms or the vaccines, anything you can tell. It will be the same. What are the vaccines which we give for a child before undergoing splenectomy? This is very important. Okay. Yes, Hib. Yes, Hib, pneumococcal and pneumococcal and you give meningococcal vaccine, meningococcal vaccine. So these are very important. So especially the cutoff for splenectomy is 5 or above 5 years. So below 5 years, getting a splenectomy done, a child dying because of severe sepsis is very high. Okay, so that is why splenectomy, if it is needed, it is done only after 5 years. Okay, so various conditions like sickle cell, thalassemia, or conditions like pyruvate kinase deficiency, they all go for splenectomy, like Biscott-Albrecht syndrome, Hodgkin's disease. Okay, so these are the various conditions which might require splenectomy. Fine. So now today's next topic, that is the lymphadenopathy, right? So now tell me, so in generally what happens is in children, a lot of children come with lymphadenopathy. So cervical lymphadenopathy is the most common presentation. Okay, cervical lymphadenopathy is the most common presentation. Okay, so basically, why does this lymph node enlarge? Because of the proliferation of the lymphoid tissue. Because this lymphadenopathy occurs because of the proliferation of the lymphoid tissue. Lymphoid. Okay, so before that, we'll talk about. Now you tell me first, when a child comes with a swelling in the side of the lymph node. Okay, so you should know first of all, is it a lymph node swelling or is it a non-lymph node swelling? So is it a lymph node swelling? So tell me other conditions which can present with mass in the neck. So tell me various conditions which can present as mass in the neck. Whatever you all know, tell me now. In children, what are the various conditions which can present as mass? So whenever a child comes with a lymph node swelling, you have to think about other differentials. What could be? Okay, so the most common lymph node swelling is in the neck most of the time. So other than that, what are the non-lymphoid lymph node swellings which can come present as? Yes, exactly, Aparna. Penicillin prophylaxis, lifelong for splenectomy patients. Very good. So now tell me, what are the various non-lymph node swellings? Yes, very good. Branchial cyst. Yes. Then branchial cyst. Then potato tumor. Okay. Yes. Next, cervical rib. TB lymphadenitis. Yeah, that thyroid. We'll go for thyroid. TB lymphadenitis is still a thyroid. Oh my God. Yeah, thyroid. Then sternocleidomastoid tumor. Okay. Ranula. Right. cervical rib, cervical rib, then thyroglossal cyst. So these are few cysts and swellings in the neck that you have to keep in mind whenever a child comes with the swelling of the neck. So most of the time it could be a lymph node swelling, but all these things should also be kept in mind. Okay, now to tell me when is a lymph node enlarged? So when do you tell a lymph node is enlarged? So it is this, the size is different for cervical and inguinal. Cervical and axillary it is same, while inguinal it is different. So how do you all tell the lymph node is enlarged? What is the measurement? What is the measurement? So any lymph node in the cervical or axillary region of more than 1 centimeter is enlarged, and in the inguinal region a lymph node of more than 1.5 centimeter is enlarged. Okay, so remember, lymph node enlargement in the cervical and the axillary region it should be more than 1 centimeter, and in the inguinal region it should be more than 1.5. So if a lymph node, so based on the characteristics of the lymph node, you can tell what could it be. Okay, so based on the characteristics, so what happens? So in a acutely, yes, very good, Deepika Karki. So if in a acutely infected lymph node, how will it be? How will it be? Acutely infected lymph node, how will it be? So an acutely infected lymph node will be tender, it will be warm, and there will be erythema of the overlying skin, right? So there will be erythema of the overlying skin. So next, if there is abscess formation in the lymph node, what will it be there? What will be there? If there is an abscess formation, yes, very good, Smith. Rubbery, matted, not in acutely infected. Okay, rubbery and matted, no. Now in abscess formation, I will tell you when it is rubbery and matted. Now, so acutely infected, you have, it is tender, it is warm, it is warm, and there is erythema of the overlying skin. Very good. Next, if there is an abscess formation of the lymph node, when you feel what will be there? There will be fluctuation. Okay, there will be fluctuance. Okay, so there will be fluctuance. You can feel it on the surface. You can feel the fluctuation of the lymph node. So if there is an abscess formation in tuberculosis, what is the characteristic feature? So tuberculosis, what is the characteristic feature? In tuberculosis, it is matted. Very good. So in tuberculosis, it is matted. Okay. Now in malignancy, how will it be? In malignancy, how will it be? So in malignancy, it will be firm, it will be firm, it will be non-tender, okay, it will be matted or it will be fixed. It will be matted or it will be fixed. Okay, so this you have to keep in mind. It might be fixed to the skin or the underlying structure. So matted is the main feature of tuberculosis. Okay, but in malignancy, it's firm, there will be no pain, it will be matted or fixed to the. Okay, so this you have to keep in mind. Next. So now, okay, I'll just continue here. So now tell me when you all call it a localized or generalized lymphadenopathy. Localized or generalized lymphadenopathy. When is it called localized or generalized lymphadenopathy? So generalized lymphadenopathy is when more than 2 regions are involved, like the cervical region, axillary region, inguinal. So when more than 2 regions are involved, it is generalized. Okay, so if one region is involved, is enough. One or it is localized. Fine. Yes, rubbery is lymphoma. Exactly. Fine. So localized and generalized. One region is okay. So now we'll talk about the various common causes or the differential diagnosis. So common causes of lymphadenopathy. So in infant, so now we'll talk about the common causes. So in infant, in a child, and in a adolescent. Okay, so when it's always infection. So the most common infection in an infant, okay, to cause generalized lymphadenopathy. Okay, we are talking about generalized lymphadenopathy. So one is syphilis, toxoplasma. So all the torch infections, CMV and HIV. Okay, so in infant these are more common. While in a child, so syphilis in a child is more rarer. So in infant it is more common to have a, yes, very good Aparna. Fine. Now child. So viral infections like Epstein-Barr virus, CMV, HIV, toxoplasma. Okay, and in adolescents it is Epstein-Barr virus, CMV, HIV, toxoplasma, and syphilis. So basically over here it's all same. Over here syphilis is not there in child and Epstein-Barr virus is not there in infant. While in adolescents all the causes are common causes of generalized lymphadenopathy is there. So EBV is there, cytomegalovirus is there, HIV, toxoplasma, and syphilis. Okay, so now coming to the various other rare causes. So in children, infant, what some of the rare causes could be what? It could be tuberculosis, leukemia, some metabolic storage diseases, histiocytic disorders, okay, Chagas disease, if it is congenital, Chagas disease. So these are some of the rare causes of generalized lymphadenopathy in infants. But while in a child, like child above 1 year, 1 year to 10 years, okay, serum sickness. So here it is more autoimmune kind of diseases like serum sickness, SLE, juvenile idiopathic arthritis, leukemia, tuberculosis, okay, sarcoidosis. Okay, so these are like most of the hematologic disorders like the Langerhans cell histiocytosis or the autoimmune diseases come in this. Okay, so over here in adolescent what happens again, the same autoimmune diseases also come. Next, other than that, there are fungal infections, drug reactions, okay, and Castleman disease. So I'll talk about Castleman disease in the last slide. So Castleman disease. So these are the various causes of lymphadenopathy. Okay, so remember first thing is infections. Commonly it is infections. Next, that in infants it is storage diseases. Okay, leukemia, tuberculosis, histiocytosis. In a child and adolescent, it's more of an SLE, I mean autoimmune kind of a disease which can cause generalized lymphadenopathy. But though they are rare causes, you have to keep in mind. So autoimmune disorders. Fine. So this you should keep in mind. So now when you have lymphadenopathy, how will you manage this child? Yes, yes, Karki, right, you're right. Yes. But again, see, that is what. Say, so in involving multi-organ, they will have generalized lymphadenopathy. But what you can see in here is the autoimmune diseases are not a cause for generalized lymphadenopathy in a small child, in an infant. So that you have to keep. So yes, what you're saying is right. But the age-wise differentiation of the causes is important. Okay, so that will help you in a clinical scenario. Fine. Next coming to the treatment. So when a child comes with lymphadenopathy, how will you evaluate? So most of the time, children come with cervical lymphadenopathy, and it is of a viral etiology. Okay, viral etiology, and generally spontaneous resolution happens. But if you're suspecting a bacterial infection, then this child should receive antibiotics. Okay, and if oral antibiotics, first you give oral antibiotics. If this oral antibiotics do not, I mean the child does not respond to oral antibiotics, then at least 1 to 2 weeks later you have to start on IV antibiotics which have an anti-staphylococcal action. Okay, IV antibiotics which is anti-staphylococcal. Okay, so this you have to keep in mind. Also, there is no response to IV also, and the child might have some respiratory breathing problem. Then you have to do investigations like USG, CT, okay, or MRI of the neck. So, when there is a child who comes with lymphadenitis and if there is pus present, you have to drain the pus and send for gram stain and culture. Gram stain and culture. Okay. Now, if the size of the lymph nodes do not decrease by 10 to 14 days, then you have to evaluate these children for other causes. Okay, so this is very important. Okay, and next, finally, biopsy should be done if there is no decrease in the to be done if there is no decrease in the size of the lymph node. This is very important. The final step is you do a biopsy and FNAC. FNAC and biopsy is done. Okay, and also this is done when there is history of weight loss, when there is history of night sweats, then when there is history of an unexplained fever. Also, a biopsy becomes very important. There you don't have to wait till the you start antibiotics and the size to reduce. When there is an associated history like weight loss, which is history of tuberculosis or history of malignancy, their biopsy is very important. So even in tuberculosis, a microbiological confirmation is very important, and therefore FNAC and biopsy becomes very important. Okay, so and other things are other conditions like Epstein-Barr virus, cytomegalovirus, cat scratch disease, and these antiseptolysin titers. All these have to be done to come to a diagnosis when it is not resolving. But if all this comes out normal and if there is no improvement in the size, you do biopsy. And other condition where do you biopsy is when there is unexplained fever, then there is weight loss, when there is night sweats, you do a biopsy or FNAC. So this is what you should be done. Okay, next. Okay, so now there are three syndromes which we will discuss. Okay, one is the Kikuchi-Fujimoto disease. Another is the Rosai-Dorfman disease or the sinus histiocytosis with massive lymphadenopathy. And then there is the Castleman disease. So these three diseases which are seen in pediatrics, but they are rare conditions. Just know about it. Just know the name. So it will at least help you if you get a difficult question. So if you see this Kikuchi-Fujimoto disease, okay, there is lymphadenopathy in this. More than if you don't remember anything else, also is okay, but you know there is lymphadenopathy. These are diseases known for lymphadenopathy. Okay, so you'll remember to remember the condition. Okay, so that is why I've used here. So Kikuchi-Fujimoto disease is more common in Asians. Okay, it's a self-limiting disease. It is seen in children between 18 to 16 years. It is seen between 18 to 16 years. So they will present with a firm unilateral cervical adenitis, firm unilateral cervical lymphadenitis. Okay, they'll have fever, they'll have malaise. Also, there is family history also is there. Family, the same case, similar cases be reported in the family. Okay, so malaise. So generally these when you get a blood test, there will be elevated ESR, there will be leukopenia, but there is lymphocytosis. So though there is leukopenia, when you get a differential count, there is lymphocytosis, atypical lymphocytosis. There is atypical lymphocytosis. Okay, so when you get a biopsy of the lymph node, you will see a necrotizing lymphadenitis. Necrotizing necrosis you see. So this is a histiocytic necrotizing lymphadenitis. Okay. histiocytic infiltration is there, there is necrosis which is seen. So this much is enough. So the treatment, is over here, it is self-limiting. Self-limiting. In severe conditions, you can try steroids. Okay, it's a self-limiting condition, and in severe cases you can use steroids. So remember this, the name itself, Kikuchi-Fujimoto disease, it sounds Asian, so you can remember this is an Asian condition. Okay, it is a self-limiting disease. There is a family cases of similar conditions reported in the family. The children between 8 to 16 years are affected, and they present with a firm unilateral cervical lymphadenitis. There will be fever and malaise. When you get a blood picture, they will show raised ESR, there will show leukopenia, and there is atypical lymphocytosis. When you get a biopsy, there is histiocytic infiltration and necrosis. So remember the name. Kikuchi-Fujimoto disease is the histiocytic necrotizing lymphadenitis. Okay, the management, it is self-limiting, but in a severe condition, you can give a trial of steroids. Fine. Next, sinus histiocytosis with massive lymphadenopathy, or the Rosai-Dorfman disease. Rosai-Dorfman disease. Even here, this is a benign and a self-limiting. See, these are all, if it comes, it is all bouncers. Okay. So I'm just putting it here so that I'm not telling you to by heart this and sit. So whenever you go back to this class, again you attend this class, so you will remember, or if you have made a notes, it will be just there. So when you turn your page, so you don't have to write everything what I say. So remember, both these conditions are self-limiting. Okay, and write this now Kikuchi-Fujimoto disease, write this histiocytic necrotizing lymphadenitis. That itself is enough for you to remember. So what is a biopsy picture? That will give you a clue. Okay, so what was I saying? Rosai-Dorfman disease is a benign self-limiting disease. This is more common in Africans and Caribbeans. Okay, over here what happens? They have big. So over here they've told massive lymphadenopathy. So there is massive enlargement, or there is bilateral, massive, painless, mobile cervical lymph nodes, or cervical lymphadenopathy. Okay, they also have increased ESR will be there, and hypergammaglobulinemia is there. So increase IgG, immunoglobulin G is there. So remember, increase ESR, increase IgG is there. Okay, so this is it, you have to keep in mind. Okay, when you do a biopsy, what will you see? You see histiocytes which are pale. Okay, these pale histiocytes are engulfed by the lymphocytes. So that is seen when you do a biopsy. You see pale histiocytes engulfed by lymphocytes. Okay, no treatment. It is a self-limiting condition. Self-limiting. In severe condition, a surgical excision might be needed. Severe condition, surgical excision. This is it. Remember. So these are some interesting names. That is why. Okay, Rosai-Dorfman disease. It is basically a condition which will present with lymphadenopathy. Okay, so there is massive bilateral, massive cervical lymphadenopathy. So there is raised ESR, raised immunoglobulin G. When you get a biopsy, you see pale histiocyte that is engulfed by the lymphocytes. So basically, inside the so inside the lymph node, if this is a lymph node or lymphocyte, you might see a histiocyte. You might see a histiocyte like this. Okay, so basically a histiocyte is, pale histiocyte is engulfed by the lymphocyte. That is the biopsy picture. Last, coming to the Castleman disease. Okay, so Castleman disease is a lymphoproliferative disease. Okay, it's a lymphoproliferative disease. So don't worry, tomorrow we are going to have a quiz. So I will have questions on all these small topics so that it will help you to remember. That is it. Okay, I'm not telling these are very very important. I'm just telling you know the names of it. It will help. I mean when you're doing a lymphadenopathy revision, so you will never uh, put all the tough points in one single page. So you're studying lymphadenopathy. So these three syndromes or diseases should be there. So that will help you to remember better. Instead putting all the syndromes together in one book or in next 10 pages, all the syndromes together will only confuse you. So in which condition this associated condition is there? In such condition, in like that, if you write, it's better. For example, yesterday we were talking about what did we talk about? Thrombotic disorder. So in thrombotic disorders, we were talking about that MYH9 gene defects. So that is seen in only such conditions, like there is congenital thrombocytopenia. So you should not confuse and put notes of only syndromes together. So only that time what happens, you get confused. So the associated topic, if you write these syndromes or these special names, it will help you to remember better. Okay. Fine. So now Castleman disease is a lymphoproliferative disease. Okay. So what happens over here? They have shown that there is an association with human herpes simplex virus 8. Human herpes simplex virus 8, and this will stimulate the production of interleukin 6. Okay, increases production of interleukin 6. Okay, so there is generally an enlargement of single node. So enlargement of single node is there. Single node. So it could be in the mediastinum or it could be in the abdomen. So it could be either in the mediastinum or abdomen. Okay, this is the most common site for Castleman disease. If for the mediastinum or the abdomen nodes to be involved, and these patients will present with fever, night sweats and weight loss. Okay, so the management, so the treatment is surgery and or radiation therapy. Radiation therapy. Okay, so there is something called as multicentric Castleman disease. So multicentric Castleman disease is involvement of the other systems. There will be hepatomegaly, hepatosplenomegaly in these patients. There will be anemia in this patient. Okay, so that you remember, just that much is more than enough. And they use chemotherapy, steroids for treatment. So in condition like multicentric Castleman disease. Okay, so along with lymphadenitis, there is fever, there is hepatosplenomegaly, there is anemia, right? So in these, what is the treatment? You treat as with the chemotherapy, steroids, rituximab could be is used. Enough, so much is enough. Just remember so much. So this is it for today. So we have discussed three nice sounding syndromes. One is the Kikuchi Fujimoto. Next is the Rosai-Dorfman, and thirdly it is the Castleman disease. So these are the conditions, are certain diseases associated with lymphadenopathy. Okay, so we'll do a fast revision of today's topics. Yeah, so basically what did I say? The spleen should be at least 2 times enlarged to be palpable. If the spleen is felt 2 centimeters below the left costal margin, it is abnormal. If there is splenomegaly and if the veins are distended in the abdomen, you have to think about portal venous hypertension. And to confirm, you get a radiology, either USG, CT or technetium scan. So in technetium scan, it will help to know the function of the spleen as well. So there are various causes for splenomegaly. So you remember the main headings, that is the hematological disorders, extramedullary hematopoiesis, infections, the various infections like bacterial, viral, spirochetal, rickettsial, parasitic. Okay, malignancies, storage diseases, immunological conditions and conditions. So always, whenever you all are talking about causes of certain conditions like hepatomegaly, splenomegaly, lymphadenopathy, you have to always know these main headings. Whenever you all know these main headings, you also remember to Yeah, deeper. I will talk about it. Okay, so this is the what is it? Yeah, so these are the various conditions which present with splenomegaly. Next, hypersplenism. So hypersplenism is what? There is increased splenic function, and as a result there is cytopenia which is the peripheral blood, and eventually what? There is cytopenia, so the bone marrow activity also will increase, and there will be splenomegaly. So that is one thing. So generally hypersplenism is always associated with some underlying disorder or a condition. So this underlying condition, if it is treated, then the hypersplenism also will become fine. In such some conditions where it cannot be treated, then in such children you will have to go for splenectomy. Okay. Next is Banti syndrome. Banti syndrome is basically when there is obstruction of the hepatic portal or the splenic vein that will obstruct the circulation of the spleen and leads to congestive splenomegaly. So that is Banti syndrome. Okay. Hyposplenism means what? There is decreased activity of the spleen. So there are, if a child is born with an absent spleen, you should think of the associated features. One is the complex congenital cyanotic heart disease, dextrocardia, if there is a trilobe lung bilaterally or not, ectopic organs. Okay, so that you should know. And more very common conditions to have hyposplenism is sickle cell anemia. There could be malaria, autoimmune diseases. Okay, like we've talked about celiac disease and various other conditions can cause hyposplenism. So very important thing in hyposplenism, when you get a peripheral smear, there is Howell Jolly bodies. Okay, so there is increase and another very important thing is in hyposplenism, there is an increased risk of serious sepsis with encapsulated organisms, and as a result, antibiotic prophylaxis becomes very important. So next coming to splenic trauma. So basically, because based on the abdominal trauma, there will be splenic injury, and so there are two types. You should remember one: a small capsular tear or a large tear. So if it's a small capsular tear, there could be just abdominal pain or a left shoulder pain. That is because of the irritation of the diaphragm due to the blood which is released. In such patients, you observe and see. If the patient suddenly deteriorates, the patient will require surgery. But in larger tear, there will be so much severe blood loss. The patient might present with hypovolemic shock. The patient might require blood transfusion and laparotomy. Okay. Splenectomy. So, splenectomy is generally done when the child is above 5 years. Okay. So, in less than 5 years, there is an increased risk of sepsis and there is a high chance of mortality. And therefore, splenectomy should be done above 5 years. And before undergoing splenectomy, the child should be vaccinated with H influenza B, pneumococcal, and meningococcal vaccine. So, now coming to the lymphadenopathy. So as you can see, lymphadenopathy occurs because of proliferation of the lymphoid tissue. Subbuccal lymphadenopathy is most common presentation. Okay, and to tell if it is enlarged or not, the cervical and the axillary lymph nodes more than 1 centimeter, while the inguinal lymph nodes more than 1.5 centimeter. The in acute infectious condition, lymph node is tender and warm and erythematous. Okay, the skin overlying is erythematous. While in a lymph node where there is abscess formation, there is okay, fluctuating mass. While in tuberculosis, it is matted, while in malignancy, it is firm, rubbery, or and non-tender. Okay, so this you have to know. Okay. So these are the various different causes for lymphadenopathy. So the treatment you all know, I have told you. So most of the time it is viral. It subsides on its own. But if you're suspecting bacterial, start on antibiotics. If it's not responding, start on IV antibiotics. And also get a USG or CT-MRI based on the condition to check if there is any associated other condition. If there is pus present, you drain the pus and send for the gram stain and culture. Conditions where the size of the lymph node is not decreased in weeks time, or if there is history of weight loss, night sweats, and unexplained fever, then a biopsy or an ST is done. So Kikuchi-Fujimoto disease is histiocytic necrotizing lymphadenitis. It is seen in the Asians. It's a self-limiting condition and it is seen 8 to 16 years of age. There is a family history of this condition, and when you get a biopsy, necrosis and histiocytic infiltration, and it is self-limiting, and in severe conditions steroids might be used. While Rosai-Dorfman syndrome is similar to Kikuchi Rheumatoid disease. Over here, it is seen in the Africans and Caribbean. And when you get a biopsy, what you see is there is pale histiocytes which are engulfed by the lymphocytes. Even here, the treatment is self-limiting, but in severe conditions, surgical excision might be needed. While Castleman disease is a lymphoproliferative disease, here they said that there is an association of human herpes simplex virus 8 causes the production of interleukin 6. Okay, so there is a single node which is enlarged. So it's most commonly the mediastinum or the abdomen which is enlarged. So here there is history of fever, night sweats, or weight loss. So it's similar to a malignancy kind of a picture. So over here, surgery with or without radiation therapy would be the treatment. In multicentric Castleman disease, fever, hepatosplenomegaly, anemia will be there. So various other organs also involved. So treatment includes chemotherapy, steroids, rituximab. So this is for today. So Deepak, Karti, are you there? So if you're there, I will discuss. Okay, I don't think you're here. Fine. So tomorrow in the quiz, I will have a discussion on the various organisms causes pyomeningitis a specific. I don't see. Okay, so tomorrow we are having quiz. It will be blood disorders. This will be around 1.5 hours to 2 hours. Okay, so it will be between 2 p.m. to 4 p.m. Okay, so for this is tomorrow on Friday. So Saturday we will have a quiz on our random pediatric quiz. So random pediatric quiz we'll have. Okay. So now tell, okay, fine. I can see Karki. So you tell me what are the uh, common bacteria which causes meningitis in a child who is less than 2 months. Less than 2 months. Yeah, Karki, tell me. So first you tell me, then I will tell. So it will, okay, I'll do discuss over here one second. Okay. So in a child, are you there, Karki? So I will discuss. So in the organisms causing meningitis age-wise. Okay. So first we'll talk about children less than 3 months. Okay. So most common is E. coli. Very good. E. coli. Then tell me what others? No, tell me less than 3 months first. First tell me less than 3 months. Only then you can remember. Less than 3 months. What other organ? One is E. coli. Streptococcus pneumoniae also causes Streptococcus pneumoniae, Pseudomonas, and Staph aureus. Okay. For children between 3 months to 3 years, it is Streptococcus pneumoniae. This becomes more important. Streptococcus pneumoniae, H. influenza, Haemophilus influenza, and Neisseria meningitis. Don't worry, this is from the main book I'm talking about. So these are the organisms. Okay, more than 3 years, Streptococcus pneumoniae and Neisseria meningitis. So remember this. Okay, so E. coli is very important, and even Listeria monocytogenes also is there. Okay, monocytogenes that also can cause severe infection in a child less than 3 months. So E. coli, so one thing we can see over here, Streptococcus pneumoniae is there in all the three. Okay, then comes H. influenza, then Neisseria meningitis is there in between these two. So this is the organisms which you have to know. So this is very important. So this you remember, so much you remember is more than enough. Okay, so less than 3 months it is E. coli, so Streptococcus pneumoniae, Pseudomonas and Staph aureus. 3 months to 3 years, it is Streptococcus pneumoniae, H. influenza, Neisseria meningitis. More than 3 years, it is Streptococcus pneumoniae, Neisseria meningitis. Listeria monocytogenes also is a common infection in a child less than 3 months. Okay, fine. So Tomorrow we are having quiz on blood disorders. Saturday we are having random pediatric quiz. So I can ask you any topic. Okay. I didn't understand your question. You should tell me what it is. Frame the question properly and give me. Random pediatric quiz. So this one will be between 2 to 4 p.m. And on Monday, if I do not finish all the questions which are intended to finish, then again I'll have a pediatric quiz. And Tuesday there will be a exclusive endocrine quiz. So this will be done. So after this a month, I'm done with all the topics what I had decided. So and in so on Sunday in special class, I will have a repeat quiz, similar quiz, that is the random pediatric quiz in the special class. That will be on Sunday. So it will be between 10 a.m. to 12 p.m. Okay. So all right. If question mention no vaccine in 2 years child, then I don't understand. I am not understanding your question, Karki. Tomorrow you tell me. Tomorrow you ask the same question. Let's see what it is. Mention no vaccine in. Fine. So all right. See you. Study well. Take care. Okay.